us his journey from medicine to specialty. And Dr. Chung, whenever you're ready to start.
Yeah. Hey, thanks guys for hanging out with me tonight, and thank you to the pre-med club at Santa Rosa for putting this together. Putting this together and allowing me to talk to you guys today. So I'm going to talk a little bit about how I got to where I am, and then just kind of go into what we do as spine surgeons, and and then go over a little bit of spinal anatomy with you guys. Let's do some learning, and then we'll go through a case, just a quick case on just a typical patient I might see in the clinic, surgical patient that I might see in clinic, and then what we might do for them. So again, I'm Andrew Chung. I'm a fellowship trained orthopedic spine surgeon, and I'll kind of talk to you guys about what that means. So I actually started out, interestingly, in chiropractic school. I thought that that's kind of what I was to some degree interested in, and then decided that I wanted to do a little bit more for my future patients, and ultimately decided to go to medical school. And I went to the Philadelphia College of Osteopathic Medicine. I then did my residency at the Mayo Clinic in Arizona in orthopedic surgery. Orthopedic surgery is a 5-year residency. And basically what orthopedic surgeons do is everything surgical and non-surgical from the neck down to the tips of the toes. So not only spine surgery, but you learn how to do joint replacement surgery. So like hip and knee replacement, shoulder replacement, shoulder surgery, sports surgery. So like athletes that get injured that need surgery, orthopedic surgeons are the ones that do those. Trauma surgery. So specifically like broken bone surgery is what is a big part of what orthopedic surgeons do. And then hand, foot and ankle, and then even pediatric orthopedic surgery is a subspecialty of what we do. And that's kind of dealing with pretty much all body parts in a pediatric patient, or of the musculoskeletal system, but also interestingly, like limb deformities, limb length inequalities. So if a kiddo is born with one limb that, or an arm or a leg that's a little bit malformed, there are things that we can do to kind of help make it normal, if you will, or even lengthen a limb. So if one leg is shorter than the other, or one arm is shorter than the other, we can actually do surgeries to kind of lengthen those. So orthopedics is a pretty cool specialty. I decided that from that, I wanted to kind of further specialize in spine. So I ended up doing a fellowship in spine surgery, training with both ortho and neurosurgeons. Neurosurgeons also do spine surgery. And then I did some extra training in some more advanced techniques. And then I currently am in Phoenix, Scottsdale area practicing. So to become a spine surgeon, there's kind of two paths. So you can either do, after medical school, you can go through an orthopedic surgery residency, which again is about 5 years. There are some 6-year programs that incorporate like a research year. So it's a long program. And then you have to do a spine fellowship, just because you typically don't have enough spine specific experience coming out of residency. Again, we deal with a lot of different body parts in orthopedics. So there's a lot of time kind of spent divvied up during those 5 years. And at the end of that, you're a fellowship trained spine surgeon. The other way you can become a spine surgeon is by doing the neurosurgical route. So you can basically do brain, they do brain and spine. And that typically is about 7 to 8 years. And again, they deal with brain, spine. They end up, honestly coming out of residency, because it's a longer residency and they're really just kind of dealing with just brain and spine. I say just, but obviously they're very complex. But they end up doing a lot more spine over that period of time. And so a lot of these guys, they come out and they're pretty comfortable doing spine surgery independently without a fellowship. But that being said, a lot of, particularly like in the big cities, like academic centers, hospitals are requiring these guys to still have fellowship training. So they end up having to do an extra year. And then ultimately at the end of that, you are a spine surgeon. So it's potentially a long path. Addie, I'll be in a little later. Okay. So what do spine surgeons do? We basically deal with the management of spine issues. So whether operative or non-operative, operative meaning surgical or non-surgical. And honestly, probably more of what we do is the non-surgical stuff. So out of, this kind of typical ratio is like you see 10 patients in clinic, and maybe 1 out of those 10 actually need, surgery. Most of the stuff can actually be treated with other kind of non-surgical treatments. And so by far, we deal with a lot of arthritis, neck and back. I'll talk to you a little bit about what that means. We also talk about, we also deal with disc herniations, which I'll talk about, spinal deformities. You can kind of see here to your right side, basically like curvatures of the spine. Not all curvatures of the spine need surgery. In fact, most don't, but in certain instances, we do need to correct them. And so right here to the right here, you can kind of see that this individual has a S-shaped curve of the spine. And then we were able to, this isn't actually my case, but we were able to straighten it out, or they were able to straighten it out with rods and screws. Trauma, so if there's any broken bones of the spine, we can fix those. And then tumors as well. We can address those as well. And I forgot to mention that orthopedics, one of the subdisciplines is also tumor surgery of the musculoskeletal system. So bone tumors, muscle tumors, soft tissue tumors, orthopedics does that as well. What I love about spine surgery really is the anatomy, and then kind of everything that kind of comes out of that as it translates into surgery. So when you look at the anatomy of the spine, it's very, you look at a spine model and it seems so simple, but really there's so much anatomy there, and and every millimeter counts. So like when you're operating around the spinal cord, for instance, like in the neck, you put your instrument, 1 millimeter in the wrong direction, and you can really hurt somebody really bad. You can get into some bad stuff. And so the anatomy that, surrounds the spine and is in the spine is just so fascinating to me. And then the amount of impact you can have with the surgeries that you do because of the anatomy that you're dealing with is just, to me, is fascinating. So for instance, you have a patient that comes in, and I'll have a case like this later on, and they have arthritis in their neck and it's pinching their spinal cord. The spinal cord is basically a direct extension of the brain, so it controls everything from the neck on down. And so if you have somebody that comes in with spinal cord pinching, they may not be able to use their hands well. They may be off balance. They can't walk. They may have weakness in the legs. They may even be losing bowel and bladder control. So they may be urinating on themselves. These are things that we see. And then by doing these surgeries, oftentimes we're able to kind of help these patients recover a lot of that function, and more importantly, prevent them from getting worse. And so being able to see that impact that you can have on patients is pretty profound. And again, it has to deal with the kind of the important anatomy that we're dealing with. Clinic and spine surgery, I think, is cool. I mean, most surgeons, they don't like clinic. And that's why they go into surgery, right? They want to use their hands. They want to be in the anatomy. I would say, in most surgical specialties, though, you have to do clinic. You have to see patients in clinic. You have to evaluate patients. You have to follow patients up. And for me, if I'm going to be in clinic, I still want to be interested, right? Like I don't want to be bored. And spine is to me, a spine patient is pretty fascinating, and they always kind of present as a unique puzzle sometimes, because when you think about the anatomy of the spine, which we'll talk about shortly. If you look just kind of the nerve anatomy, you've got brain, spinal cord, and off the spinal cord, particularly like for instance in your neck, come all these electrical wires, that we call nerves, that ultimately go down the arms and control our ability to feel our arms and our hands, and allow us to move certain muscles and so on and so forth. What can happen though, if you have arthritis in the neck or disc herniation, again, we'll talk about what these things mean, is the nerves can get pinched. When they get pinched, you can get pain radiating down the arm, or weakness in a particular part of the arm. And the thing that can confuse people oftentimes is that, hey, is this truly coming from the neck, or is this like is it a shoulder problem? Is it an arm problem, right? Because you have all this anatomy in your shoulder, your elbow, your forearm, your wrist, your hands, that can also become what we call pathologic, right? They can also cause problems and cause pain. So being able to distinguish between, hey, is this truly a neck problem or is this a extremity problem? That can be fascinating part of clinic. Again, I don't need to talk about the surgery. You can, it's great anatomy. You can really, affect patients' function very profoundly. And then the technology that we have in spine surgery is just getting better and better. When you look at the history of spine surgery, like the people that came before me, people started spine surgery back like in the 1900s. Kind of started mainly with orthopedics, a little bit of the neurosurgery, and then we kind of blended together eventually in terms of what we do in spine. But if you look at kind of the technology and the way that it kind of advanced over the first, let's say, like 90 years, so like from like early 1900s to like 1990, like 2000, it was kind of like this, like kind of a slow increase. And then over the last like 10, 15 years, the technology has just really kind of the improvements in technology have really just skyrocketed, and our understanding of spine, it has skyrocketed. And so the technology that we have available for use today is just awesome. It's really cool. Some of the stuff that's demonstrated here is, we're doing kind of what we call minimally invasive surgery. So traditionally, if we were to do, whatever it is that we're doing here, it'd be a big kind of midline incision right over the spine, and you're just kind of opening everything up. Now we're kind of able to do it, the same surgery through these small incisions, through tubes, just based on the technology that we have. We've got robots and things like that kind of help us to put in screws and stuff like that into the spine. So you can kind of see a robot arm here, getting set up to do that. So bottom line is, spine surgery to me is fascinating. For me, it's like I get bored really easily. So I need to be doing something that's going to keep me interested, continue to challenge me, and isn't going to be stagnant. And when you look at the trajectory of spine surgery, it's just going to continue to advance, and it's going to continue to keep me, at least for me, interested. And that's why I love it. I write a loose weekly schedule because really the schedule of a surgeon just depends on a few things. So one, it depends on kind of what we call the practice model that you're in. So you can work for a hospital system and be employed by the hospital system. Or, what some people do, probably half people do, is they go into private practice, where essentially you're kind of your own boss, and you work with others, and you kind of are your own bosses and kind of control your own destiny, if you will. If you're part of a hospital system, they may kind of dictate, when you operate, when you have clinic, your responsibilities and so on and so forth. When you're in private practice, oftentimes you get to kind of choose, hey, these are the days I want to operate. This is when I want to do clinic. I want to operate at this hospital versus another hospital. So that's why I write, loose schedule here, because it really just depends on, what your personality is and the type of practice model you want to go into. But typically, the schedule is going to be some mix of, operative days where you're in the OR, doing surgery, and then clinic days. And then weekends, depending on kind of what your practice structure is. You may be taking call, you may not be, you may just be rounding, or you may have people that are doing the rounding for you if that's kind of what you choose. And so again, there's a little bit of flexibility there as far as your schedule is concerned. Just a few pictures inside the OR, just if you guys have never stepped foot in the OR. That's me in the back. This is at Cedars when I was a fellow there. And just some of the things that we're looking at here. This patient is, face down on a typical OR table that is radiolucent. And the reason for the radiolucency is that we use a lot of X-ray interop to kind of, figure out where we are. Radiolucent meaning, obviously it's kind of clear under X-ray, right? Monitors everywhere. Anesthesia is up here. Patient is ventilated right now as we get prepared for surgery. This is a case that we use the robot. So here's kind of the robot monitor and kind of the console, if you will. There's a person that typically kind of operates that for you. Again, another monitor so you can visualize what they're looking at there during surgery. Here's the robot arm. This is a circulating nurse that's about to basically kind of sterilize the patient's back so that we can start prepping for surgery. This is not the same day or same institution, but just kind of showing you how we prep for surgery, wash the entire hand and arms up to the elbows. And typically we either use like a soap and brush, or you can use a gel even to do that. Wearing loops. Loops are, basically like little magnifying glasses on our glasses, and allow for about a threefold magnification, so we can see a little bit closer the anatomy that you're dealing with. And then typically, if we're working through small incisions, oftentimes in the spine, we wear a headlamp so we can see in there. A little bit of blood here coming up, so hopefully you guys are okay with that. If you're squeamish, just kind of look the other way, and I'll tell you when you can look back. But this is a case where we use the robot, and this is kind of showing mainly what, at least for now, what the robot is used for is to basically insert screws into the spine. It just allows for a little bit more accuracy, kind of takes out the quote unquote human error. So this is me drilling basically the track for a screw into the spine using the robot, and what we call navigation. Yeah. Some other cool toys that we use is a microscope to the left here. And basically this allows for even further magnification beyond loops and a very clear kind of three-dimensional view of what you're dealing with. So when you're dealing with very delicate anatomy, or you're kind of working through a small hole, the microscope is very useful. This to the right here, we're getting set up for computer navigation. And so basically how this works is we put an array on the patient, him or herself, and basically we spin like an intraoperative, what we call CT scan, like a fancy x-ray. And then basically we're able to kind of locate on the body where we are using these tools, navigation tools, based off of this array, that intraoperative CT scan. And that allows us, again, to kind of work through very small incisions to kind of figure out where we're going without having to open up the entire spine. So a lot of cool toys that we're able to use. This is just showing a case being done through a minimally invasive approach. Again, typically, back in the day and still nowadays, you do surgery through a big, what we call midline incision. You kind of open up the spine, see everything, and it's easier to kind of know where you are. Well, now we can kind of do these kind of same surgeries through tubes and basically, have patients have a little bit less pain after surgery, and they typically, kind of recover faster as a result of this. So just kind of giving you an idea of how small some of these working spaces are. You can kind of see here that, I'm drilling through this kind of small area, and I'm drilling bone. And so you really got to know where you are, right? Like a millimeter really matters. If you drill a millimeter in the wrong direction, you could be, drilling into nerves and stuff like that. So you really need to know what's going on there. So basically what we're doing here is we're drilling some bone away. We're kind of collecting it because we can reuse it. And then ultimately we're drilling down so that we can kind of take the arthritis off the nerves. Okay. I'll be right in, okay? All right, let's talk a little bit about spinal anatomy. So when we talk about the spinal column or vertebral column, essentially has two functions. It kind of keeps us upright, supports the weight of the body, and then it protects the spinal cord and all the kind of nerve anatomy. When we talk about the nerve anatomy, obviously we've got the brain, and then the direct extension of the brain is the spinal cord, and that's kind of in the neck. And it extends all the way down to kind of the mid lower back. And at that point, you have what's called the cauda equina. So all the nerve roots in the low back are just kind of swimming in this sac of fluid that we call the cauda equina in your low back. And then all those nerves, whether coming from the neck, coming from the legs, control different parts of the body, your sensation and certain muscle groups. We have four distinct curvatures of the spine, and these are natural, normal curves. And so by the time you're kind of walking and upright, we have what's called a cervical lordosis, or kind of a backwards curve of the neck. We have a thoracic kyphosis, which is kind of forward bend of the mid back, and then lumbar lordosis, again, kind of backwards curve in the low back, and then a sacral kyphosis. And everybody has, a different degree of normal, right? So you guys may hear like kyphosis is like a deformity. It's really not. Like we all have kyphosis. When it becomes excessive, or if it's too little, then that could be considered a spinal deformity. When we look at kind of the general structure of the vertebrae, this is kind of looking top down on it. Here's what's called the body. And basically the body acts as, basically a big kind of platform to kind of support the weight of the body. So it's very strong. And on top of it lies what's called the disc, which we'll see in the next slides. Behind the body is the spinal canal, or vertebral foramen, where live the nerves. And so again, you can kind of see that you've got all these kind of bony ring surrounding that spinal canal that protects the nerve. So it's protected. Pedicle, I point that out because this is where we put our screws. We actually shoot them right like this. And this is how we get fixation in the spine, and we're able to, create fusions in the spine, which I'll show you an example of coming up. And then we've got all these little processes. Processes are just attachment points for muscles. So there's a lot of muscles in the low back. Without getting into the weeds, to me, muscles are very important, right? There's a reason why nature kind of created muscles for us. And so where traditionally we used to kind of go in through the mid portion of the spine and kind of just basically fillet off the muscles from all of the spine like this. One of the reasons for minimally invasive surgery is that the idea is that you're preserving those muscles as much as possible, because we think that they're very important, right? I mean, it's almost like common sense. Like, nature gave us muscles. Shouldn't we try to preserve them? Well, for a long time we didn't. So anyway, that's kind of the general kind of theory behind minimally invasive surgery, is that if you preserve the muscles, patients end up doing better. When you look at the discs are like shock absorbers. They exist between these bodies of bone, between adjacent vertebrae. And basically, again, they're like shock absorbers. The outer portion, they're almost structured like a jelly donut. So the outer portion, which is called the annulus fibrosus, is made of very kind of dense collagen, called type 1 collagen. And basically, it's nice and strong. The inside is called the nucleus pulposus, and it's about 88% water. And so that's kind of what gives that shock absorption effect to the disc. And so kind of interesting fact is, basically throughout the day, as you're kind of loading the spine, a lot of that water kind of diffuses out of the nucleus pulposus into the adjacent bones. And so by the end of the day, you're actually shorter than you were when you started out the day. And then when you lay down and sleep at night, the water kind of gets back into the nucleus pulposus. So in the morning, you're taller again. So just kind of a fun fact. And as these discs wear out, which they do, and that's kind of what we call arthritis in the spine, that's where a lot of people lose height. So like you may notice that like an older individual, they may be, a couple inches shorter than they were when they were younger. And part of the reason is again, they're kind of losing the height of the disc because that water content is going away. And that's just part of the process of disc aging and arthritis of the disc. So I had talked about disc herniations earlier. Basically what a disc herniation is that this portion of the disc can actually kind of pop out the back. So this kind of gelatinous material can pop out the back. And the reason why that happens is, one, as we age, things kind of get a little less healthy. Maybe you get a little bit of tearing in the annulus, that kind of outer ring. And then right in the back, you can't see it here, but right in the back of the disc, there's a ligament there called the posterior longitudinal ligament. And so that actually typically prevents that disc from going backwards, but right next to it, there isn't any ligament. And so if there's a little bit of weakness there, because of tearing or something like that, then that disc can actually pop out the back. So about 98% of the time, we get disc herniations in that what we call posterior lateral corner of the disc because of that kind of weak point in the disc. And the problem with that is that when the disc pops out, what's back here are the nerves, right? And so if it pinches on a nerve, then you can get, pain or even weakness kind of going down the leg. In worst case, if it pinches on all the nerves, that are kind of living in that spinal canal, you can get what's called cauda equina syndrome. And that is a surgical emergency for us because that starts to affect your ability to go to the bathroom and things like that. So again, pedicles are important for us because this is where we throw a lot of screws. This is kind of where we get fixation into the spine. Pedicles, even though they're small, they have a lot of good bone in them and, you know, allow for nice fixation. So like this is an example of, you know, ton of pedicle screws in the spine to kind of ultimately straighten out the spine, which I wish I had that before, but it was relatively crooked. So we've got this technology now that allows us to do this. And this probably developed over the last 20 years or so. So it wasn't always that we could do this type of thing. So just to kind of illustrate the arthritic process, if you look here, kind of the top disc, that's what's normal, right? Nice and healthy looking disc, nice and tall. The nerves are nice and free here, right? And we actually have these little joints in the back called facet joints. And they're almost like little knee joints. Now, when we look at the kind of mechanics of the spine, 85% of the load of the body goes through this front part. It makes sense, right? It's bigger, it's got the disc, it's designed for that. The problem is as this disc wears out, which it inevitably does, you know, basically it kind of dries out, the blood supply to it gets, you know, poorer and poorer as we age, and essentially it eventually wears out. And what ends up happening is these little joints in the back and some of the ligaments back here have to do more work because the front of the spine is not doing its job anymore. So these little guys in the back have to, you know, work harder to, you know, make up for that. And what ends up happening is they get thicker and they become arthritic. And when they get thicker, we call that hypertrophy, right? So hypertrophy is anything that gets larger in response to, you know, some stimulus. And so they get hypertrophied, the ligaments get thicker to work because they're working harder as well. And the problem is that there's only so much room back here for the nerves. So if everything else is getting bigger around the nerves, then, you know, those things can start pinching the nerves and causing pain. And not to mention arthritis itself causes pain. But where it really becomes problematic is, again, when it hypertrophies and starts to pinch on the nerves, and then people will come in with like leg pain or weakness, very similar to a disc herniation. But this is more of a, you know, versus disc herniations, which is kind of typically like, you know, acute onset, meaning, you know, somebody will be doing something and maybe they twist in the wrong direction and that disc pops out. And causes pain and you know, weakness because it's pinching on a nerve. Arthritis happens obviously over, you know, a longer period of time. Again, vertebral canal contains all the important kind of nerve structures of the spine, and it's the largest in the cervical spine because we've got cervical spine being the neck because we've got the spinal cord up there. In general, the cervical spine, the vertebral bodies are smaller. Really just the vertebrae in general are smaller because they don't need to do as much work, right? They're just only holding up the head. And then again, this is the level of the spinal cord. So those neck bones are protecting the spinal cord, and then off of that, at each level comes the spinal nerves, and in the neck, those nerves control our ability to feel and move our arms and hands. Lumbar vertebrae by far are the largest because they're at the base of the spine and they have to do the most work. So just to kind of go through a quick case, give you an example of, you know, what we might see in clinic and, you know, the types of surgery we might do. This is a 61-year-old male who comes in with some neck pain that's gotten worse over the last 3 years. Now, neck pain is pretty common. About 80–90% of people will get neck pain at some point in their life. And so for us, neck pain really in itself is not an operative indication in general. And so what questions do you want to ask? Well, you know, I kind of talked about much earlier, you know, what happens if, you know, you get spinal cord compression in the neck. That's a bad problem. So this is going to be one of those patients. So basically, you know, you want to ask, hey, is there any symptoms that kind of are, you know, consistent? Symptoms being, what does the patient feel, right? So do they have any, you know, issues with pain going down their arms or weakness in their arms? So any radicular symptoms, again, symptoms being basically symptoms or feelings or concerns that are a result of nerve pinching. So oftentimes, like, numbness, tingling, pain going down the arm, or even weakness in the arm, those would be examples of radicular symptoms. So this patient has no radicular symptoms, but what he says is over the last 5 months, he's had, and I wrote symptoms twice here, symptoms of gait imbalance. So he's kind of feeling off balance, feels like he can't, walk well because he's like stumbling over his feet. And then he's also losing his fine motor skills. So maybe he can't write, his penmanship's worsening. Maybe he can't button buttons. Maybe he's having trouble, picking up small objects, or he's even dropping things. And things that he's tried some physical therapy. Physical therapy is kind of one of our standard kind of non-surgical treatments. They go to the physical therapist, and do some neck strengthening, stretching, things like that. He tried anti-inflammatory medications like ibuprofen or Advil, but really, that hasn't happened. And what's most concerning to him is the functional issues, right? He's off balance. He can't use his hands, and so that's kind of what's concerning to him. Anytime you interview a patient, you want to get a sense of kind of what their history is, right? History is important because if they've got significant medical issues, that's going to change, maybe how you decide you want to treat that patient. For instance, if they need a big surgery and they've got, like significant heart issues, lung problems, kidney issues, maybe they can't recover from that surgery, and maybe you're going to offer them something a little bit different, because at the end of the day, you can do the best surgery in the world, but if the patient's not going to survive it, maybe it's obviously not worthwhile, right? So all of these things kind of matter when you're developing a plan of what to do. So he's had some heart disease in the past, and he's got some stents in there. He also has vertigo. So again, going back to like the spine patient being kind of a clinical puzzle to me, which I find fascinating. Vertigo is an inner ear related issue, and essentially it's the sensation that the world is kind of spinning around you. And so oftentimes, people will kind of confuse maybe true gait instability, where they can't actually find their feet, with kind of the world kind of spinning around them, and that's why they're off balance. So you got to be able to kind of distinguish, the two, and there are ways to do that based off the exam and so on and so forth. But again, another reason why I like the clinical aspect of spine. Again, he's tried some anti-inflammatories. He's a former smoker, or he's a current smoker, and these things matter, because smoking actually interferes with bone healing, and so maybe you want him to quit before he starts. Before we do surgery on him, or if you need to do surgery more urgently, maybe you do things to kind of optimize the fusion. And there are ways surgically we can do that. So you change your technique a little bit. So all of these little pieces matter. Not every patient is the same. Not every surgery is the same, even if the problem is similar. So what do you want to do next? Well, we want to examine the patient, right? Always, if I can impart anything on you guys that are going into medicine or surgery or whatever, always get a good history, always do a good exam, because a lot of what you kind of figure out, like basically the diagnosis oftentimes will come from that if you're good, and it should. And then the imaging and the labs and stuff like that should really be confirmatory. You should never do the opposite, where you look at the imaging first, look at the labs first, and then kind of work your way backwards. Because oftentimes, as you guys will learn, those things can fool you. There's a lot of abnormals that are actually normal in many patients. And so if you start there, then you're kind of going down the wrong road already. So always start with a good history, always start with a good physical, and then use the other stuff to confirm what you're already thinking in your mind. Exam. So he's strong. He doesn't have any, evidence that some nerve, output is diminished to a muscle group, right? So he's fully strong. He does have some numbness in the C8 bilaterally. C8 is kind of the outer hand pinky. So basically, when you map out what each one of these nerves in the neck or low back kind of controls as far as sensation, you can actually correlate, or it has actually been done, where you correlate different nerves with different, kind of sensory patches in the hands or the arms or the legs. And so C8 is typically kind of this area here. So maybe some evidence that the C8 is pinched or whatever. He's got a bilateral Hoffman's. Hoffman's is just evidence that maybe he's got some spinal cord compression, and then he's unable to heel toe walk. So kind of going back to the idea of vertigo versus like gait instability, his sense of balance is actually off at a kind of a nerve level. He can't walk from heel to toe. So this is kind of your sobriety test, right? So when you drink a lot of alcohol, it actually affects your balance system. And so in this case, when you have spinal cord compression, it's very similar. It affects your balance. So what's next? We want to get some imaging, and basically, not to get into the weeds here, but basically he has arthritis in the neck. This is looking at him from the side, and you can kind of see here there's something kind of junky going on here when you compare it to kind of these levels here. And then this is an MRI. MRI kind of shows us nerve structures really well, soft tissue structures really well. And so to not belabor the point, basically here's brain up here, here's spinal cord, and normally it should be surrounded by fluid like this, but you can see that it's getting really pinched right here. And there's actually even some signal change in the spine itself. So what that means is normally the spinal cord should be gray. You can see here it's white. So it's actually, what that means is it's actually scarred and it's actually damaged. And then this is just showing how pinched it is. This is what we call an axial section, where we're kind of cutting the patient like this and looking down on them. And here's a spinal canal, and you can see that basically that spinal cord is getting pinched. So what do you want to do? Well, he's myelopathic, right? He's got basically myelopathic, meaning he's got evidence of cord compression and he's symptomatic from it. This is something that we typically don't wait on because it will progress, and if you wait long enough, patient will come back in a wheelchair, not being able to walk or use their hands, maybe even urinating on themselves. So this is something that you do want to address sooner than later. And so what we did was a C5-6. C5-6 just being the level that was problematic. We did what's called the anterior cervical discectomy infusion, and I'll kind of show you what that is. But basically, you go in there, you scoop out the arthritis from the front, and you put a little spacer in there that allows for those two bones to fuse, and then you put a plate and screw construct on there to kind of hold things in place. This is the way that we do it. Basically, we go in through the front of the neck. We push the windpipe and swallowing tube out of the way. We push the like carotid artery and we call the jugular vein out of the way, and then we access the spine through the front. So again, anatomy is fascinating, right? You're working around some pretty important structures, and you're able to do some cool things between them. And so this is just kind of showing that right now. We've made an incision through the skin. Basically, we're finding that interval between those muscles, and we're about to go down through that interval to get to the spine. A little bit of gore here coming up. So if you're a little squeamish, just kind of look the other way. It's just kind of a video of what it looks like once we're down there. This is us working on the spine through the front again. And basically what we've done already is we've actually cleared out the disc, and we're actually working behind the bones there to clear out some of that arthritis around the nerves in the spinal cord. And so we're using what's called, this is bipolar cautery. It's just a very gentle way of cauterizing bleeding and stuff like that. That's a suction. So we're just kind of suctioning some of the blood. But essentially what we're doing is, again, kind of clearing the arthritis off of the spine. I think we've kind of finished there, and not quite. Clearing some more. We're using what's called a kerrison. It's just kind of it's a very small, kind of delicate tool to kind of slowly clear up some of that arthritis that might be pinching on stuff back there. I'm going to fast forward a little bit just because it's kind of more of the same here. And right now we're just kind of checking with what's called a nerve hook to make sure the nerve's nice and free. That's actually the spinal cord right in the middle there. And so we've cleared off a lot of it. Now you can kind of get a sense of what we're looking at. Here's the body and of the vertebrae above, below. And again, we cleared out the disc, worked our way to the back of the spine, cleared it off. And now what we're doing is basically trialing, what's called trialing. We're putting a metal kind of spacer in there to see how big of an implant we want to put in that space. And then now we're basically what we're doing there is we're drilling holes for the plate and screw construct. We're about to drill holes for it. trying to drill there. Isn't it cool? You're literally drilling. It's like you're drilling into a wall, but you're not. You're drilling into a spine. So I mean, it's kind of cool stuff to get to do. So we've pre-drilled our holes. And now we're kind of just irrigating everything. Standard stuff we do in spine, just to kind of clean everything up. That stuff is called flow seal. It basically is it's an anticoagulant essentially, or a hemostatic agent rather. It is an anticoagulant, but basically it just stops bleeding. Not anticoagulant, procoagulant. And then now we're putting the spacer in there, which has a little bit of kind of what we call like bone product or biologic. And essentially the idea here is that it's going to keep that space nice and open. And then it has bone products in there that are going to allow for those adjacent bones there to fuse together. So that's what we're doing. And then I think that's it. And then we would put a plate and screw construct on the front, and that would be in the case. We close up, and that would be all. So that's all I got for you guys. Hopefully that was interesting. Hopefully you guys learned something. And that's a little bit of what we do in spine.
If you guys have any questions for Dr. Andrew, make sure to leave it in the chat. But I do have some questions for you. It was really interesting to watch the videos of the surgeries actually happening. Thank you for sharing those.
Yeah.
Yeah, but I was going to ask you, how was your journey from going attending a DO school to like going to a competitive surgery like residency?
Yeah. That's a great question, and I won't sugarcoat it. I think it's getting easier now, but at the time, it was hard. At the time, the DO and the MD residency were separated. So you could either kind of go the DO route and do a DO residency, or you could go the MD route and do an MD residency. And the benefit of doing an MD residency, at least at the time, now they're kind of all under one umbrella, but at the time, is that it would probably give you more access to better fellowships. They typically had more kind of brand name recognition. Which again translated into potential to get better fellowships, and then they tended to just be more academic, so they had more research opportunities and things like that. So for me, I wasn't sure whether or not I wanted to teach or go into academics versus not, and so I just kind of wanted to keep those doors open, and then also just maximize my chances of getting into a more academic fellowship for, again, that same reason. So that was kind of my decision as to why I kind of went out of the DO match and went into the MD match. Now, the problem with that is that there, at least at the time, and it probably still is, in fact, there is some bias against DOs, just because you kind of have a lot of older guys that are, in the field, and that's just the way it is. And probably more so, it's just that, these fields, like orthopedics specifically, is very competitive. And so they really can be very picky with the applicants that they get. So the way that I kind of, the analogy that I have is like, if you have a guy or gal that's coming from like Harvard, okay, versus a guy or gal that's coming from, let's say, like, Glendale Community College or something like that, who's going to look a little bit more favorable application wise, right? It's going to be the person from Harvard. Now, if they take a closer look, hey, they might find that the guy or gal from Glendale Community College actually had very good test scores and did a lot of research or whatever it is. But in general, when you've got so many applicants, especially in these competitive specialties that are coming from these kind of bigger name institutions, that on paper, not only do they have that, but they've got all the other qualifications that pretty much everybody else have, they're probably going to start picking from the more recognizable pot, if that makes sense. And so as a DO, you're typically coming from a program that most people don't recognize. And that makes it tougher for you. And so for my year, there were probably half the places that I interviewed at had never interviewed a DO before. And there was definitely, I could kind of sense a little bit of bias along the trail. My year, there was only one DO, myself, who matched into an MD orthopedic residency. I think nowadays it's getting a little bit more, a little less competitive, just because now we're kind of under the same umbrella. So DO and MD residencies are now under the ACGME umbrella. But I think in general, if I'm to give advice to, people, do I go DO or MD? I think if you want to keep the doors as open as possible, particularly if you're considering a very competitive specialty, I would say make it easier on yourself, right? Like try to just get into the best program possible. And it's almost common sense, but like, if you can get into a recognizable MD program, that's probably going to make things a little bit easier for you. Now, it's not a guarantee, right? There's folks, for instance, this year, I know folks at a very good, reputable medical school that was affiliated with my, residency program that did not match in orthopedics, and they were stellar applicants, and they were coming from a very reputable institution. So it doesn't guarantee that you get in, but it definitely makes it a little bit easier. And so why wouldn't you do that for yourself? So long answer, but basically, I think as a DO, it's going to be a little bit harder to get into those competitive specialties. Not that you can't do it, but if you have the opportunity to go to a more kind of recognizable school, I think you're gonna be thankful that you did in the end. Now, that being said, I wouldn't change my journey at all. I think that, me being a DO and kind of having to really fight to get to where I wanted to go kind of made me who I am today. And so I wouldn't change that for a minute. So I don't look back with regret, but I just advise, you guys, just make it easier on yourself if you can. I don't know if that helps you.
Yeah, that was a really good answer. Thank you. I have a question from Yuna. She's asking, are patients almost guaranteed a healthy spine after surgery and recovery?
Yeah, no, that's a good question. So oftentimes no, and I'll tell you why. Like in orthopedics, we do a lot of hip and knee surgery. And the analogy that I always give patients is that, you've got one hip on the right side, you've got one knee on the right side. So if we replace your hip or replace your knee, we're kind of good, right? Your hip or knee is replaced and you've only got one on that side, right? In the spine, you've got so many segments, as you guys saw, right? And oftentimes, by the time we see these patients, they're usually like in their 60s and 70s, because that's kind of how long it takes for arthritis to kind of become symptomatic or become problematic for patients. And so they may have one level that is really the source, one or two levels that are really the primary source of their issues, but the rest of their spine may be, already arthritic. And so what I always tell them is like, hey, listen, like we're not making your spine a 20-year-old spine again, right? In order to do that, we'd have to pretty much fuse the entire spine, which even then you've lost mobility and you're not a 20-year-old again. We're only addressing the levels that are truly causing your major issues. Now, at those levels, it does help, and it does make them feel better, and hopefully makes them feel like they're younger. But there are some consequences to that. So anytime you fuse a spine, you get rid of some mobility in the spine, and so they may feel a little bit stiffer. Or if you fuse the neck, neck spine, most people think low back, but neck too. You fuse the neck, maybe they're a little stiffer in the neck, so you lose some mobility. So to answer your question, you're not really, you're addressing the problem, but you're not making their spine brand new by any means.
Another question from Olivia. It says, do you treat, I don't know how to say it, it's sciatica, and if so, how can it be treated?
Yeah, so sciatica is basically, so the sciatic nerve is the nerve that kind of runs right in the back of your butt. It's the biggest nerve in the body. It runs in the back of the butt, and then it goes down the back of the thigh, and basically branches both to the front and the back of the leg. And so it's the biggest nerve that controls kind of the lower extremity. You have some other nerves that control it too, like the femoral nerve and stuff like that. But the reason why people kind of called sciatica is that the most common, so when you look at the anatomy of the nerves, right? So you have all these nerve kind of electrical wires that come off the spine, right? All those nerves ultimately kind of come together in the lower extremity and create these what we call peripheral nerves. So one of those peripheral nerves is the sciatic nerve. So the sciatic nerve is just a continuation of nerves from the spine. And so what people call sciatica is actually usually just pinching of one of the nerves in the low back, and it will cause pain down the back of the leg, back of the thigh. And so one of the ways we can address that is if, for instance, it's caused by a disc herniation in the low back, you go in and you kind of take that disc herniation out. If it's caused by arthritis, then you kind of clean up the nerves, do a fusion if you have to. That's the majority of the reasons why sciatica happens. Is it's usually low back in origin. Now there are what we call it like peripheral causes of sciatica, meaning the sciatic nerve can actually get pinched. And that can actually cause that similar type of pain kind of going down the back of the thigh. So that can happen with things called piriformis syndrome, where the piriformis muscle is the muscle where the sciatic nerve actually exits under. That can actually kind of get thickened and actually pinch the nerve. You can get hamstring issues. You can get like tumors and stuff like that can kind of pinch the nerve as well. So there are other reasons why you can get sciatica, but by far and large, it's usually the low back that causes sciatica type pain. Sciatica is just another word for kind of radiculopathy, going down the back of the thigh, back of the leg. I don't know if that helps.
I hope it helped Daisy. I think it was Daisy.
All right.
I had another question about your work-life balance with being an orthopedic surgeon.
Sure.
And there was another question about like if the amount of patients you get as working in a hospital versus on your own in a small clinic.
Oh, like let me see, where was that?
Like private practices versus hospitals.
Oh, is the volume of patients lower with private practice compared to hospitals? I think it just kind of depends. It depends on where you are. It depends on, like for instance, if you're, in a big city, big hospital system, then yes, you might be, very, very busy at a hospital. If you're in a smaller town, and you're at a, hospital there, maybe you're not as busy. And it's the same thing with private practice. The beauty about private practice, though, is you can kind of decide how busy you want to be, right? At the hospital, if you're employed, you just have to do your job. Unfortunately, you get paid what you get paid, and you do your job. Otherwise, somebody's going to tell you to do your job. In private practice, you can be as busy as you want to be, or you can say, well, I don't want to be as busy. I want to see less patients. Now, you have to balance that with, compensation, right? Like you have a certain lifestyle you want, you have a certain amount of money you want. And particularly when we come out of, residency in medical school, we've got a lot of debt typically. And so you kind of have to, kind of do what makes sense for you. But as long as you're happy with the amount of money you're making, you can be as, less busy as you want in private practice. Or if you want to be very busy and just do a lot of surgery, hopefully good surgery, you can do that as well. So that's the beauty of private practice. And again, it just really depends on the volume. Really just depends on where you are, and the volume that particular kind of city sees.
I have a question from Yuna again. She says, what would you do different if you were able to start your orthopedics journey again? Which I think you kind of answered at the end of your presentation.
Yeah, I think I would just, here's what I tell everybody. I think, even starting in medical school, I just wish I paid more attention in general to things that I didn't think I'd be interested in, or I wouldn't need. I think all of the disciplines, they all matter to patient care, right? And the more that you know about internal medicine or nephrology or cardiology or pulmonology or whatever it is, you get those opportunities to learn those things in medical school, even if you're, going into ENT or orthopedics or whatever it is. All of those things matter for your patient's health, right? I mean, you can't do a surgery on a patient. You can't do a big surgery on a patient that's got, renal failure, right? I mean, you can, but they're going to be very high risk of having complications. So if you're able to kind of understand those things very, very well, the kind of implications of medical issues on surgical outcomes, that makes you a better surgeon. And if you're able to understand and communicate with the specialists and the hospitalists about medical problems, that makes you a better team player too, which makes you a better doctor. And so if you pay attention more during medical school, and then even in orthopedics, like, luckily I paid attention, but there are a lot of people that they kind of know what they want to do, and they kind of forget about all the other stuff. And that's a problem, right? So like if you're a hand surgeon and you never paid attention when you were on your spine rotation, and you don't know how to differentiate between a hand problem and a spine problem, you may be doing surgeries on patients that don't need to be done. And so just pay attention during your journey.
Harminder has a very good question. She says, what did you do, or what could she possibly do to set herself good for matching in ortho as a DO?
Oh, I think it's, I think it's all kind of the kind of standard stuff, right? Get good grades, do well on your boards, try to get involved in research, get good letters of recommendation. I mean, that's big. So I would say, start working, developing relationships with orthopedic surgeons early, and particularly if you can, orthopedic surgeons in academic centers or places that you want to go, or that have connections to places that you may want to go. Those things matter. Connections matter. Orthopedics is a very small field, believe it or not, particularly in academics. Everybody knows each other. And so if you've got, ex-surgeon at, let's say, I don't know, like UCLA or something like that, like, making a phone call for you at some, to some program that, he or she trained at, or even at UCLA, that goes a long way. That makes up for the fact that maybe you're coming from a less known school, right? If somebody that program, the people at that program know is like, oh man, this applicant, she's great. She's a hard worker. She's going to be a great orthopedic surgeon. That makes a big difference when all else is the same. If you've got all the good grades and you've got all the same, board scores and research opportunities, somebody vouching for you makes a big difference. The other thing that's huge is away rotations. So you'll have opportunities during your fourth year to do what's called an audition rotation, where you actually go to the institutions that you're kind of most interested in, and maybe spend a couple of weeks, or usually about a month, just kind of rotating with them. And it's almost like an extended interview, right? Like you're learning orthopedics, but at the same time you're trying to show them, hey, I'm ready to belong here. I do belong here. I work hard. I'm more than just test scores. I'm more than just a DO. I'm actually, a good team player. I work hard, and I'm going to be a great orthopedic surgeon. I'm going to be somebody that you want to work with daily, and you want to train, and you're going to be proud of training me, when all said and done. And so that's what's really going to, make the difference. So all the other stuff, the stuff that's on the paper, those things are expected. The way that you stand out, the recommendation letters, and probably most importantly, the way rotations. Now, it's important to know stuff, right? You want to be knowledgeable and so on and so forth. But I think more and more people are appreciating people that are team players and are kind of socially adept. So people that can get along with others, people that make good doctors that can interact with patients, people that know how to play as part of the team, that aren't annoying. You have a lot of people that are just overeager, or they think just by like spitting out all this knowledge that it's going to impress people, and that actually annoys people. You want to be somebody who, when they're asked a question, knows the answer. You're not trying to show off. You're just there to work hard, and just be a part of the team. That's the type of person you want to be, and those are the types of people that end up matching into orthopedics. It's very simple, but you'd be surprised how many people don't get that. So again, that's why the away rotation is so important, because you can kind of showcase that. That's who you are. Just be a humble, hardworking person, and just a good person, team player, no job is too small for you, and you're going to go far. I mean, it's so simple, but there's a lot of people that don't do that.
I know we are a little over time, but if you have the time, you have a couple more
Sure.
questions. Yeah. Okay. I have a question that says, how did you deal with the stigma of being a DO, and how did you keep yourself motivated during your time in medical school?
Yeah. Yeah. It's a good question. I used it as, for me, I think there's kind of two camps, right? Like, you can easily look at that stigma and get all, hurt about it, and it can negatively affect you, right? You could be like, oh man, like, well, I'll never make it as a DO. Or you can use that as almost a challenge to yourself. And that's what I did. And I was like, well, shoot, everybody says I can't do it, but I think I can, what do they know? And so I worked harder because of it. And that's why for me, I wouldn't change that route, because it made me, if you saw me 15 years ago, I mean, you would never think that I would be where I am. I was a much different person. I didn't really study very hard, I wasn't really, like, very regimented in my routines. Like, I kind of just like to hang out and go out and stuff like that. The fact that I was a DO and had to overperform to get to where I am today, and work harder, I think, than many people kind of typically have to do. I think that kind of made me who I am. And so that's how I dealt with it. And that's how I would recommend that you deal with it, is you kind of use it as a challenge to push yourself to kind of be like, hey, you know what? You don't think I can do it? Well, I'm going to show you. I'll do it. So.
And is there anything you dislike about orthopedic surgery?
Yeah, I don't like the foot. I don't like smelly feet. I don't like diabetic feet. So yeah, I just don't like foot and ankle. I always give my buddies that are in foot and ankle a hard time because they have to look at feet all day, and I'm just not a big fan of it. But some of the surgeries that they do are cool. Is that what you're talking about? Is it more about the day to day or specific?
I think just whatever you feel like. Yeah.
Okay.
And Daisy asks, what is something you wish you knew or did before applying to medical school?
What is something you wish you knew or did before? I think I used to look back, when I was kind of first starting this journey in medical school, and when I saw how much of a kind of uphill climb it was to go into orthopedics, I was like, man, like, should I wish I studied harder. I wish I did everything right, and went to the best medical school possible, right? Like that's kind of what I wish I did. But then, as I kind of got further along in my career, I actually started to really appreciate, my path to medicine, because, I took longer to get here. And ultimately that made me, really gave me time to kind of figure out exactly what I wanted to do, right? Like I actually started out in accounting, and then I was like undeclared for a while. And then I went to chiropractic school, right? And to be completely, honest with you guys, transparent with you guys, the only reason I went to chiropractic school is because my dad told me to go. So because he was like, man, you got to do something with your life. Why not try, chiropractic? I work with a chiropractor. He seems to, enjoy his job. And so, I didn't know what I wanted to do for a long time. And ultimately when I kind of came to, medicine on my own, that made me more passionate about what I wanted to do. So I took longer, but in the end, I now know that this is exactly what I want to do. And that actually helps. And so one of the things that I tell people is make sure whatever it is that you decide to do, whether medicine or whatever career you guys decide, make sure you're doing it for the right reasons, particularly if it's a very demanding field, which medicine can be, particularly surgery. If you're doing it for the wrong reasons, you're not doing it for the patients, you're not doing it because you love it. If you're doing it for like money, prestige, or because your parents tell you to do it, I can guarantee you're going to get burned out, and and that's going to suck, because I've seen that. You get into residency, they're 3 years in, and they just can't handle it. And so you've gone through medical school, you've gone through residency, you've gone this completely different route where you may have been much better in tech or something like that. I'm just making this up. And now you got to start over from scratch, and you've invested all this time and money into this thing. So just make sure you do it for the right reasons. And so again, when I look back, I'm glad I took longer to kind of figure out what I wanted to do. And more importantly, it gave me life experiences and helped me to meet people that I wouldn't have normally met. And to me, it just kind of made me a little bit more well-rounded when it came to kind of the social aspect of things. So I wouldn't change it. I used to think I wanted to, but I would encourage you guys, if it takes an extra year to kind of figure out what it is that you want to do it. I mean, in the grand scheme of things, a year to figure out what you want to do with the rest of your life is not a big deal. What is a big deal is if you rush into something and when you're already in practice or even during residency, you decide, hey man, like this isn't for me. That sucks, right? Because then you wasted years and years, not just 1 year, you've wasted years and years. So anyway.
I have one last question from Harminder. She
Yeah.
says, how do you know you wanted to do ortho in your 3rd or 4th year as opposed to every other specialty?
Yeah, so I kind of knew I wanted to do ortho. When I was in chiropractic school, I actually had, that particular school had an opportunity to work in the cadaver lab. And what kind of interested me the most was the musculoskeletal system, and specifically the spine, because chiropractors obviously focus on the spine. The other thing is I was a personal trainer. So I loved, the musculoskeletal system to begin with. So being able to surgery on it, and when I actually saw what you could do, the fact that you could just improve so dramatically somebody's function, I mean, that's huge. Like, I would encourage you guys to shadow as many specialties as you can, as you're kind of figuring out what specialty you want to do. Like, don't get locked into one specialty, because you may find, if you just kind of, you're like, oh, I know I want to do this because it seems really interesting. And then you've never actually kind of, given opportunity to look at something else. You may find that you're missing actually your true kind of passion, right? So I would encourage you guys, for instance, like if you go into like an orthopedic, like a joints clinic, and you see like some old lady that walks in with a bad hip that hasn't been able to walk for a year, comes in a wheelchair, and then they have surgery, and the surgery takes like an hour, hour and a half. And that day they're up and walking, and they're so thankful for the ability just to walk again and just to like play with their kids. And that's huge. That's a big deal. So that's what I loved about orthopedics, is that you can restore function to people with your own hands. And that's an amazing feeling. Just to kind of, I think I'm seeing this question in front of me. I'm just looking at it. I think somebody was the stigma of being a DO and surgery. I don't know if you were also asking about like now, but I will tell you that once you're out, it's really like, there's no difference. If you're a good doctor, that's all that matters. Yeah, getting into residency can be hard because it's just like, comparing different types of, reputable schools. But once you're out, all that really matters, all other doctors and patients care about is how you treat patients and how you interact with other people. If you do a good job, you're reading, you do science-based work, you're not doing weird stuff, and you're treating people with respect, and you're being a team player, that's what's going to make you a good doctor by far, and that's what's going to make you a well-respected doctor by far. It's not the degrees after your name or necessarily where you trained at.
Thank you, Dr. Chung, for taking time out of your busy schedule to talk with us today. It was very informative.
You're welcome.
Yeah, thanks.
Well, good. Thanks for inviting me. And if you guys have any questions, just feel free to message me at any time. All right. Take care, everybody.
Have a good night. At this time, if you guys, we have a Google link posted in the chat. Feel free to go in. And we don't have an assessment for today, so just make sure to check in to receive credit for your hour, and try to use one email throughout all the sessions so it's easy for us to track your hours. And our next event is happening on March 28th with Dr. Valerie Caucho. She's a physician in internal medicine, so stay tuned for that. And thank you very much, guys.